Chromoendoscopy with targeted biopsy improves the diagnostic yield of IBD surveillance colonoscopy compared to white light colonoscopy with random biopsy. However, the use of chromoendoscopy is not common in routine clinical practice. In our article entitled A Roadmap to the Implementation of Chromoendoscopy in IBD Colonoscopy Surveillance Practice, we suggest steps for the integration of chromoendoscopy in routine IBD colonoscopy surveillance practice. Recently, an international multidisciplinary group, SCENIC, Surveillance for Colorectal Endoscopic Neoplasia in IBD Patients International Consensus, sought to develop unifying consensus recommendation addressing how surveillance colonoscopy to detect dysplasia should be performed and how the dysplasia identified at colonoscopy should be managed. Chromoendoscopy with targeted biopsy is now endorsed by many gastrointestinal professional societies as the preferred technique for dysplasia detection. Compared to white light colonoscopy, chromoendoscopy with targeted biopsy identifies a significantly greater proportion of patients with dysplasia with a relative risk of 1.8 and absolute risk increase of 6%. Chromoendoscopy with targeted biopsy increases the likelihood of detecting any dysplasia by 9 times and the likelihood of detecting flat dysplasia by 5 times. This study shows that compared with non-IBD patients, the IBD patients were 3 times more likely to have had a colonoscopy within 3 years prior to cancer diagnosis. A significant proportion of these interval cancers were advanced cancers, suggesting dysplasia was missed at the baseline colonoscopy. Clearly, optimizing surveillance methods for dysplasia and cancer detection in IBD patients is needed. This case demonstrates the additional value of chromoendoscopy for clinical decision-making in IBD surveillance. This patient with long-standing ulcerative colitis underwent surveillance colonoscopy. At first examination, using high-definition white light endoscopy, a subtle appearing flat elevated lesion was observed. Chromoendoscopy helped to delineate the borders of the lesion and highlighted the epithelial surface. Targeted biopsy was taken, showing dysplasia. Endoscopic resection was recommended instead of colectomy. A colonoscopy performed 6 months before showed active colitis but missed dysplasia. Using modern endoscopic examination, most IBD-related dysplasia is visible. In this case, stepwise examination of the colonic mucosa reveals important detail. Upon detection, long-view examination using white light endoscopy permits to estimate the lesion size, shape, and location. Then, application of indigo carmine dye clarifies the borders of the lesion and facilitates diagnosis. This is a non-polypoid, completely flat colorectal neoplasm. Varying expansion of the colonic lumen and close-view inspection allow more detailed characterization of the epithelial surface and vessel pattern. Targeted biopsy of this villous-appearing lesion showed dysplasia. In this patient with Crohn's colitis, colonoscopy revealed a small isolated ulceration. Biopsy was taken showing low-grade dysplasia. Subsequent pancolonic chromoendoscopy was performed showing a non-polypoid superficial elevated neoplasm with ulceration. Chromoendoscopy with targeted biopsy revealed a poorly differentiated adenocarcinoma. The technique of chromoendoscopy is easy to perform, as demonstrated in this video. Using high-definition instruments, dilute indigo carmine is applied using the forward wash jet. When lesions are identified, more concentrated indigo carmine is applied via the biopsy channel to better delineate the lesion extent and the mucosal detail. Targeted biopsy are then taken of the lesion and the surrounding mucosa to exclude flat, invisible dysplasia, which would render it endoscopically unresectable. We briefly describe the materials needed and how to perform the chromoendoscopy technique. For detection of dysplasia in IBD, we spray dilute indigo carmine through the forward wash jet, targeting all suspected mucosal abnormalities. Then, more concentrated indigo carmine is applied with a syringe via the biopsy channel to better delineate the lesion extent and the mucosal detail. We interrogate the epithelial surface using different dye concentrations as shown here. Varying the concentration depends on the goals. For example, if the solution is too concentrated, then it can make the color dark and hinders inspection. Likewise, when selectively spraying indigo carmine on a lesion for detailed inspection, if the solution is too weak, then it does not enhance visualization or contrast. Detailed algorithms to performance of pancolonic chromoendoscopy with targeted biopsy for surveillance in IBD are now available. Like every tool, chromoendoscopy imposes limitations even as it opens opportunities. Potential barriers at patient, physician, and systemic level include lack of basic knowledge, lack of skills, and skepticism of IBD thought leaders on additional value of chromoendoscopy, leading to inertia among clinicians. Insufficient bowel preparation, presence of disease activity, and compliance issues may hinder application of chromoendoscopy. Also, perceived need for additional accessories, equipment, and additional time, and current lack of reimbursement. There are several solutions to these potential barriers. Systematic training using atlases, videos, and web-based learning, familiarization of the colonoscopist with the equipment, material, and standard operating procedure, and partnered learning with an experienced colonoscopist. Personalized intake for colonoscopy, counseling, and coaching of the IBD patient to improve compliance. High-definition colonoscopes, water pumps, and most accessories are already widely available. New reimbursement methods centered on quality and effectiveness and monitoring of quality metrics should be promoted. To successfully implement chromoendoscopy in IBD surveillance practice, training is undoubtedly the first step. In an academic practice, the gastroenterologists were familiarized with the performance of chromoendoscopy and image interpretation. Subsequently, they assessed dysplasia detection in 75 patients with chronic ulcerative colitis using white light endoscopy followed by chromoendoscopy. Chromoendoscopy detected significantly more dysplasia than white light endoscopy. Notably, the median colonoscopy withdrawal time decreased from 31 minutes for fewer than 5 procedures versus 18 minutes for 5 to 14 procedures and leveled off thereafter. An economic analysis comparing chromoendoscopy with targeted biopsy versus white light colonoscopy with random biopsy versus no colonoscopy concluded that chromoendoscopy was more effective and less costly than white light colonoscopy at all surveillance intervals, supporting the implementation of chromoendoscopy in routine practice. What are the next steps? Training and self-training using a wide palette of educational tools and programs such as videos, atlases, books, and freely available websites to provide insight on endoscopic technique and findings. Monitoring of quality metrics such as detection and resection of dysplasia, the interval cancer rate during IBD surveillance, and reduction of the colectomy rate will help to identify and close current gaps in performance. Reimbursement that appropriately compensates providers for the additional costs and complexity of performing image-enhanced surveillance colonoscopy should be promoted. Further clinical study will facilitate risk stratification of IBD patients and inform changes in evidence-based, cost-effective surveillance recommendations. For more information, please visit the gastrointestinal endoscopy website and the following freely available websites. Thank you.